Firstly, I would like to thank BSAVA for accepting this abstract and for arranging this remote seminar series. My presentation is entitled Development of a Novel Diagnostic Prediction Tool for Cushing Syndrome in Dogs using Primary Care Electronic Patient Records. I do need to disclose that I am currently undertaking a PhD, and this is sponsored by Royal Veterinary Products. Cushing syndrome is one of the more commonly occurring endocrine diseases in dogs. However, it can be difficult to diagnose. And the main reasons for this are the low prevalence of Cushing syndrome in the general population, with vets in primary care practice typically seeing around 2 to 3 cases a year. Clinical signs are non-specific to Cushing syndrome. There are no highly accurate diagnostic tests, and these tests can be overused. Therefore, a new diagnostic method for Cushing syndrome is warranted, and the objective for this study was to explore whether new diagnostic methods could be developed from clinical record data, and in particular to see whether a prediction tool for Cushing syndrome could be developed. So this tool could be used by clinicians to evaluate individual patient risk of the disease for use prior to confirmatory testing. So at the point of suspicion of Cushing's, the tool could indicate which dogs are most likely to become a case and which are most likely to be falsely suspected of Cushing syndrome. Therefore, this could aid clinical decision making in practice. Data from this study was collected through VetCompass, which holds a large amount of anonymised primary care electronic patient records from UK veterinary practices. And this allows for large generalised samples of primary care data to be analysed. And in this particular study, there were 886 practices included. So from the VetCompass data, dogs attending veterinary practices in 2016 were included. And this was the 905,000 dogs at the top. From this, search terms were applied to the clinical records of these dogs, and those with a mention of Cushing's or a synonymous term were identified, which was 10,000 dogs. And from these, 62% of records were analysed manually in detail to identify dogs eligible for inclusion into the study. And this was based on sample size calculations. 398 cases were identified, and these were dogs diagnosed with spontaneous Cushing syndrome by the attending vet in the clinical records. They had to have had an ACTH stimulation test or a low-dose dexamethasone suppression test recorded in the records, and dogs were excluded if the diagnosis was later questioned. There were then 541 non-cases included, and these were dogs where Cushing syndrome was suspected and tested for with either an ACTH stimulation test, low-dose dex test, or a urine cortisol creatinine ratio, and they had to have had Cushing's excluded in the clinical records and an alternative diagnosis made. So these two groups were chosen to mimic the population of dogs in primary care practice, where vets are unsure one way or the other about Cushing syndrome. And for these cases and non-cases, clinical signs, laboratory results and demographic factors at the point of first suspicion for Cushing's were extracted. In the methods to develop this tool, there were 3 main steps. Firstly, a multivariable logistic regression model was built and then internally validated on a proportion of dogs that were not included in the model development. The regression coefficients of this, the model developed, were then used to assign points to the tool. And finally, the predictive likelihoods were calculated for each possible combination of additive points, or a points total. So I will work through this with the results that we obtained so that this all becomes clear. So this is the model that was developed by multivariable logistic regression, and there were 10 predictive variables that were included in the final model. Points were assigned to each parameter based on their coefficients, and this resulted in a total possible score that could range from -13 to 10. And for each possible total score, a predicted likelihood of Cushing syndrome was calculated. Therefore, a dog receiving a score of -13 reflects a 0% likelihood of that dog having Cushing's, whereas a score of 10 reflects a dog with a 96% predicted likelihood of having Cushing syndrome. So this is just a further breakdown of some of the predictive factors that were included. So these were the 3 demographic factors, which were sex, breed and age. So if I just talk through with age, this indicates that dogs that were 7 years or older had a greater risk compared to those that were less than 7 years. Therefore, those aged 7 years plus were assigned 1 point in the point system, whereas dogs less than 7 would receive no points. There are also clinical factors included, which were clinical signs and a few laboratory factors. So again, if we look at polydipsia, if polydipsia is present, dogs are allocated 2 points as they have a larger risk of having Cushing's than those where no polydipsia is present, and those with no polydipsia would receive 0 points. The model was found to have a good performance during internal validation, and it had an area under the ROC curve of 0.78. If people are unfamiliar with interpreting a ROC curve, the 45-degree line on the curve represents a test that is the same as tossing a coin, so not very good. And if a curve was in the very top left corner, this would be a perfect test, which would receive no false positive or negative results. So the curve that is represented here for the tool indicates that this has a pretty good discrimination. I'm now just going to talk through 2 scenarios to indicate how this could be used in practice. So the first is a case of a 6-year-old male entire Bichon, which comes into practice with polydipsia, a pot belly, elevated ALKP and a dilute urine-specific gravity. So this dog with our score would receive 6 points, and that is equivalent to having an 84% likelihood of Cushing syndrome. This is then compared to another case that might walk through the door, which is a 9-year-old male neutered crossbreed that comes into practice also with polydipsia, but is also vomiting, has a raised ALKP on bloods, and a normal urine-specific gravity. So this dog would have a score of -2, which equates to 20% likelihood of having Cushing's. So these probabilities could be used by vets in practice to make decisions around whether further testing for Cushing's is warranted. So perhaps in this case, with a 20% likelihood, other differentials are worth investigating before Cushing's to avoid overuse of those diagnostic tests. The study does have some limitations, namely that there was poor recording of some laboratory factors in the electronic patient records. Therefore, only a few of these could have been considered in the model development. The performance may also differ when applied in practice and in different practice populations to those in VetCompass. Also, as the diagnosis of cases or non-cases was based on those recorded in the clinical notes, there could have been some misclassification of cases and non-cases. But this is likely to be comparable between the two groups and would have diluted the coefficients towards the null. In conclusion, this study has described the development of a diagnostic prediction tool for Cushing's syndrome in dogs. Its use is from the point of first suspicion of Cushing's and for vets within primary care practice. The benefits of the tool could be that it directly aids clinical decision making. It is easy to perform and to interpret. So finally, I would just like to thank my PhD supervisors and others working on this project. I would also obviously like to thank my funders, DECRA Veterinary Products, and thank all of you for listening. I would really welcome any questions or comments or anyone to send me an email. All right, thank you.